Hi, my name is Emily Brown, and today we are going to be talking about the clinical anatomy and significance of major structures within cadaver prosection, or also known as Kinesiology 3519. So, the basic agenda for this presentation is to go over an important structure that we discuss throughout each unit and kind of unmasking that and going more on the clinical side of things into what the clinical manifestations are if either of these structures don't work properly. So, the first structure that I'm going to discuss, we learned in Unit 1, and that is the femoral artery. So, there are many branches to the femoral artery. You have the common femoral artery, as we can see in this drawing right here. Let me get another color. And then it branches into the deep femoral artery and then the superficial femoral artery. So this is a major blood supplier of blood from our heart to our lower limbs. So as I just said, the common femoral artery is that main branch of the femoral artery. It extends from the external iliac artery, supplying blood to the groin and pubic region. And then it branches into the deep femoral artery, which supplies blood to the thigh, femur, hips, and your butt. And then we have the superficial femoral artery, which is going to be superficial or on top of that deep femoral artery. And as it states right here, it supplies blood to your knee and your quadriceps muscle, which makes sense, as your quadriceps muscle is the most superficial muscle within that thigh region. Another important fact is that the wide diameter of the femoral artery makes it a prime site for endovascular procedures. So doctors can actually use that femoral artery to get to the heart, which is super interesting. And then potential complications can arise within the femoral artery, known as peripheral artery disease and critical limb ischemia, which we'll discuss on the next slide. So for the pathophysiology of peripheral artery disease and critical limb ischemia, so this picture on the left is showing pitting edema, which, if you can see those little pits right here, that's where the pitting comes from. And then obviously you can tell that his right leg is significantly swollen. So when the common femoral artery narrows or the artery becomes blocked by plaque or fatty acids, this can cause atherosclerosis, which is hardening of that artery, which over time leads to peripheral artery disease. So risk factors for this are hypertension, obesity, older age, diabetes, vasculitis, smoking, and more, which makes sense, as all of these factors have been linked to a disruption in your blood flow. And then symptoms of PAD include discoloration of the extremities. As we see here, there is a little bluish tint within his right leg extending to his foot, cold limbs due to lack of blood flow, claudication, and in extreme cases, necrosis of the tissue. And normally when you have necrosis of the tissue, they have to cut it off, or gangrene of your toes. So one other cool thing that I found during my research is that the femoral artery presentation is not always the same in every individual. On that last slide, we looked at a diagram of the common femoral artery branching into the deep and the superficial. But sometimes there's an absent deep femoral artery, or the common femoral artery will branch into two. So that's super interesting. Another abnormality that can be present is the lateral and medial circumflex arteries will branch off the common femoral artery or the superficial artery instead of the deep femoral artery. These abnormalities can lead to critical limb ischemia, which is the more serious form of peripheral artery disease. And these symptoms are severe pain in lower extremities, even while resting. All right, so next we're going to be talking about the brachial plexus. This is coming from our second unit, which dealt a lot with our nervous system. So ultimately, the brachial plexus is this large branch of nerves that come from your cervical and thoracic spine, and they extend all the way down into your forearm. And these nerves are ultimately responsible for not only the sensation of your forearm, hands, and fingers, but they also ultimately control movement as well. So there are 5 major nerves in the brachial plexus that we talked about. Obviously, there's more than 5, but I just kind of thought I would break it down just to that more basic level. So first we have the musculocutaneous nerve. So first off, I'm going to say that how we learned it in lab, there's this big M right here, and we actually used it a lot to be able to find different nerves. And so the first kind of line of the M, if you're going left to right, is the musculocutaneous nerve right here. So to find it, you're going to go down C6, down the lateral cord, and at the end right here, it becomes the nerve. So you can see that there are kind of different divisions along the nerve region, C6 to the cord, to the nerve, and it was really cool to kind of see where those divisions were in person in lab. So anyway, the musculocutaneous nerve main functions is to help flex the muscles at the shoulder and the elbow, and it innervates the biceps brachii, coracobrachialis, and brachialis muscles. The next nerve is the axillary nerve. So this actually is behind this M, going from the root, or C7, down the trunk into the division, down the cord, the posterior cord, and here's that branch right here of the axillary nerve. So the main function of the axillary nerve is it helps in shoulder rotation and abduction, and it innervates teres minor and deltoid muscles. Now moving on to the median nerve right here. This is kind of the middle of our M, or the median of our M. So if we go down here, we have, it kind of is the intersection of C8 and T1. You're going to go down the medial cord to the median nerve. So the median nerve is super important. It helps in movement of forearm and certain regions of your hand, and it innervates the flexor digitorum superficialis, the flexor carpi radialis, the palmaris longus, and the pronator teres. So these play a super important role in flexion of your hand. Next, we have the radial nerve, which is also on that posterior cord by the axillary nerve, but they both branch off of the posterior cord and kind of go separate ways. So C7, you go down to the posterior cord, and the radial nerve's at the end right here. So the radial nerve helps in movement of the upper arm, elbow, forearm, and hand, and it innervates the extensor carpi radialis brevis, as opposed to the median nerve, which innervates the flexor carpi radialis. They sound similar, but they do different things. And then the ulnar nerve makes that kind of little last line of that M here. So you're going to go down T1 to the medial cord, and the ulnar nerve's at the end right here. And the ulnar nerve helps in more precise motor control of your fingers. So it innervates the flexor carpi ulnaris and the flexor digitorum profundus. So we will talk more about the clinical manifestations if these nerves get damaged on the next slide. And then going on to the case study. So what happened in this brachial plexus injury? So basically I read this case study on the NIH, And basically it discussed a 28-year-old man who was in a car accident. He was riding on a motorcycle and a car hit him out of nowhere. And so motorcycle versus car, car's gonna win. So he had some pretty extensive injuries. So basically, he had a brachial plexus injury on the left side of his body, which was extensive, and he had to undergo supraclavicular brachial plexus and neurolysis surgery. So, I actually learned this the other day. Brachial plexus injuries are commonly on one side rather than both. So it's rare to have a brachial plexus injury on both sides. It's normally on either your left side or your right side. So some symptoms when you have a brachial plexus injury like this: you'll have a distortion in the number of neural impulses getting to that sensory motor complex. So this basically means that you'll have a decrease in sensation, either in your upper arm, your forearm, or your hand, just depending on what nerve is specifically damaged, because as we just discussed, there are 5 major nerves within the brachial plexus, and they each innervate different muscles. And then additionally, a significant amount of regenerating axons will not be able to reach their receptors because they're trapped in the scar interface. So again, the signaling is going to be disrupted. And then the final main symptom is other axons will reinnervate the incorrect sensory receptor or a degenerated receptor that is irreparable. So these axons will attempt to communicate with each other, but ultimately, because that nerve is damaged, this will not be able to happen. And then on the left, this is his x-ray. As we can see, both his ulna, which is right here, and then the radius, which is right here, they are both fractured. His elbow is right here. So that is a pretty nasty fracture. And obviously he had to have surgery, I imagine, have a cast for a long period of time. But specifically for the nerve damage, he underwent neuromuscular electrical stimulation for nerve regeneration as well as rehab. So after doing that for a 6-month period, he is now able to do a lot of things on his own again, like driving a car, but he still has trouble with more precise movements like cutting food. So, unfortunate for him, but this is just one of the realities of having such an extensive brachial plexus injury like this. And this is actually the patient. I was kind of surprised that they were able to put an image of him in this. But this is him basically extending his left arm and abducting his left arm, which he wasn't able to do initially right after his injury. And through physical therapy, the electrical stimulation, now he's able to do more precise movements like that, which is awesome. So now for our final structure that we learned in Unit 3, along with the rest of the heart as well as the brain, is the pulmonary trunk. So the main function of the pulmonary trunk is to transport deoxygenated blood from the pulmonary arteries to the lungs. And another interesting fact is that it is the only exception to an artery that transports oxygenated blood. So normally you learn that arteries transport oxygenated blood from the heart to the extremities, and veins bring deoxygenated blood back from those extremities to the heart. But the pulmonary trunk carries deoxygenated blood, but it's still considered an artery. So I thought I would mention that because that is the one exception to that general rule. But back to the main point. So one condition that happens a lot when the pulmonary trunk kind of has an interference as the patent ductus arteriosus does not close properly. So when the ductus arteriosus does not close properly after birth, oxygen-rich blood flows back from the aorta, as we can see in this diagram, through the pulmonary trunk, and then gets into the pulmonary artery, and then gets into pulmonary circulation, which is a problem because oxygen-rich blood is not supposed to mix with oxygen-poor blood. So this is actually pretty common, present in infants. Normally when an infant's born, they're born without that closure, but then I think it's within the first few weeks that is supposed to close up, but sometimes in infants it'll take longer or it just won't close at all, and then they'll go in and do surgery. So again, for treatment, surgery, and then if surgery is not an option for whatever reason, then they'll try pharmacotherapy. So this is another case study I found, and this case study focused on a 46-year-old female who presents with pulmonary artery dissection, and the patient also had the underlying condition of patent ductus arteriosus, as we talked about in the last slide. So what is a pulmonary artery dissection? It is a very fatal complication associated with pulmonary hypertension, which leads to tears in the surrounding arteries. So obviously, this can be pretty fatal as it is potentially interrupting blood flow of multiple arteries. So the patient came in to the ER with symptoms of chest pain, shortness of breath, substernal pressure radiating to the shoulder, and nausea. These are pretty common symptoms of someone with a heart condition. And she additionally had a low blood pressure of 95/60, which makes sense because if her arteries are tearing, there's obviously not going to be as much blood flow within those arteries, which can lead to a lower blood pressure. So this image on the left is a chest x-ray of the patient. And it shows an enlarged heart right here. The heart's normally not supposed to be that big. And it also shows pulmonary overcirculation, shown by dilated hilar vessels and pulmonary arterial segments. It also shows a dilated pulmonary trunk. The dilated pulmonary trunk is in this image right here. If you're not seeing an x-ray, it's a little hard to decipher, but pulmonary trunks are supposed to be a little smaller in a typical x-ray. The patient, unfortunately, did pass away, as it is typically very hard to recover from a pulmonary artery dissection once, multiple arteries are torn. All right, and here's my works cited. Thank you so much for watching. I hope you enjoyed my discussion of 3 of the several structures I learned in cadaver prosection, and I hope you learned something. So thank you so much.